Today's lecture is entitled The Pelvis, or, as we say in the business, the pelvis. What happens in the pelvis does not stay in the pelvis. My name is Carlos Andres Suarez-Quian. I am the author and will narrate this presentation for you. The pelvis, also called the bony pelvis or pelvic girdle, is a basin-shaped complex of bones that serves as an intermediary connection between the trunk and the legs, supports and balances the trunk, and contains and supports the intestines, the urinary bladder, and the internal sex organs. The objectives for this portion of the lecture are listed here. I will not read them to you, but instead they will appear as slide headings when I am discussing the particular component of the pelvis. Let's start with the first objective. Describe the structure of the bony pelvis, including its joints and associate ligaments. Here we see two pelvises, a male pelvis on the left and a female pelvis on the right. The principal distinction between the two is the subpubic angle. In the male, the subpubic angle is generally below 70 degrees, whereas in the female, it will be greater than 80 degrees. Before DNA testing, this was often the only physical feature available to forensic scientists to distinguish the sex of bones found at a crime scene. Each pelvis consists of two hip bones and one sacrum, so named because it reminded first anatomists of a sacred bone. In addition, at the tip of the sacrum is the coccyx, a small triangular bone formed by 3 to 5 rudimentary coccygeal vertebrae. These bones represent your tailbone and resemble the beak of a cuckoo bird, hence its name in ancient Greek. Each hip bone consists of 3 separate bones, the ilium, ischium, and pubis, that generally fuse at about age 16. The 3 bones meet at the acetabulum, the cup-like area visible on the external view of the hip bone, and is where the head of the femur articulates with the hip bone to form the hip joint. If you pursue a career in obstetrics gynecology or orthopedic surgery, you will need to learn quite a bit of structures associated with the individual hip bones as shown in the slide. For this course, however, we do limit the structures to know to those relevant for understanding how nerves and vessels enter and leave the pelvis and are of clinical relevance. These include the anterior superior iliac spine and iliac crest, already noted when we studied the abdominal cavity, as well as the pubic tubercle. The ischial spine and the ischial tuberosity. Indeed, if you're sitting down watching this video, you're likely sitting on your tuberosity, not your coccyx. That would be painful. The greater and lesser sciatic notches and the obturator foramen. Interestingly, the notches are converted to foramina by ligaments in real life, whereas the obturator foramen is almost closed by membranes and muscles. Finally, we go back to this image of the intact sacrum and coccyx to demonstrate 2 additional features that will be of interest in following discussions. These 2 structures are the sacral promontory at the uppermost boundary of the sacrum and the arcuate line. We will go into more detail about all these structures in a second. Next, we need to understand how these bones are attached to one another by the ligaments. Again, there are many ligaments in the pelvis, but let's focus on the principal ones. In this anterior view of the articulated pelvis, we observe the pubic symphysis in between the two pubic bones. For reference, I left the inguinal ligament, which we learned about, in the abdomen. Between the articular surface of the ilium and the sacrum, a very strong anterior sacroiliac ligament is present. And if there is an anterior sacroiliac ligament, there has to be a posterior sacroiliac ligament. It should be clear that these ligaments must help maintain the integrity of the pelvis when we are standing upright. Indeed, these ligaments help transmit all the weight of the trunk down to the hip bones and the legs, and yes, they can be the source of significant pain due to inflammation caused by wear and tear on the joints, for example, degenerative arthritis. Two other ligaments bear mentioning at this time, the sacrotuberous and the sacrospinous ligaments. The terms for these ligaments are descriptive of their attachment points. Not only do they contribute to the stability of the hip bones on the sacrum, specifically, they allow us to walk upright, but as well, by their attachments, they create two foramina. The greater and lesser sciatic foramina. Important nerves and vessels exit and re-enter the pelvis via these foramina. Indeed, some have argued that the nerve that exits and re-enters the pelvis via these foramina is what makes life worth living. And here's a drawing of the pelvis bisected in half to better demonstrate the two foramina, the greater and lesser sciatic foramina. Try and remember this image, especially when we discuss pudendal nerve block in the female just before parturition. There is another aspect of the pelvis that is illustrated in this drawing. It represents the actual orientation of the pelvis when we are standing up. In the coronal plane, which is illustrated in the image, the anterior superior iliac spine is in the same plane as the pubic tubercle. What this means is that when we are standing up, the cavity of the pelvis is angled obliquely posteriorly, not down towards the floor. Let's focus on this more now. Having described the bony pelvis, we should emphasize that as with any other region of the body, the pelvis is also defined relative to its related areas. For example, look at the two drawings in the slide. On the left is a drawing of the body in the sagittal plane, and on the right, the body has been drawn in the coronal plane. The region of the pelvis is in red, and it sits below the abdomen and above the perineum. One feature about the pelvis, however, that is not shared with the abdomen is that there is no physical separation between the abdominal and the pelvic regions, as there is between the thorax and the abdomen. Indeed, we can think of the abdominopelvic cavity as one contiguous space. Any fluid present in one area can move freely to the other, and it does. As you know, however, there is an actual muscular barrier between the abdomen and thorax, and we call that barrier the diaphragm. And to complete the description of the drawing, there's also a muscular barrier between the pelvis and the perineum. We will describe these muscles shortly. Finally, let's consider what we think about when we say pelvis, given that the abdomen and the pelvis are contiguous. Let's go back to our hip bone and look at the bony landmarks. Remember the arcuate line? Anything above the arcuate line will be considered to reside in the false pelvis. This will include the abdominal content that extends into the area protected by the pelvic bones. In contrast, below the arcuate line, in the area indicated by red, we will find the true contents of the pelvis, for example, the prostate in the male and the uterus in the female. These are the soft tissue structures we will focus on when we do this area. We have described the bony pelvis and its location. The next question to address is what are the features of the bony pelvis that are assessed during prenatal exams to evaluate adequacy of the pelvis for childbirth. Indeed, talk to any late pregnant woman near term, and one question they will have is whether they are large enough to deliver by natural childbirth. The answer lies in pelvic dimensions of the pelvic inlet and outlets. Let's describe them now. In this image, the red circle indicates the pelvic inlet separating the false pelvis above from the true pelvis below. The dimension of the pelvic inlet that concerns us is that of the obstetrical conjugate between the sacral promontory and the upper margins of the symphysis pubis. Conjugate, by the way, is used in the sense of joint. It is the narrowest distance of the pelvis that the baby's head needs to cross. However, the conjugate cannot be measured directly because of the bladder. Instead, what is done, a fairly accurate measurement of the obstetrical conjugate is estimated by performing a pelvic exam and measuring the diagonal conjugate. After withdrawing the hand, the difference in length between the index and middle fingers will grant the length of the obstetrical conjugate. The pelvic outlet dimensions are also important to note. These include the interspinous distance that represents the narrowest part of the pelvic canal. The distance is not fixed during labor. If 3 fingers can be inserted into the vagina during a pelvic exam, it is safe to assume that the ischial tuberosities are far enough apart and the subpubic angle is considered sufficiently wide to permit the passage of an average fetal head at full term. The last area we need to consider with respect to the pelvic bone is how structures from the pelvis continue on down to the lower limb. There are a lot of details specifically concerning this transmittal of structures, but for now and for this course, we will just touch briefly in the subject of nerves. Again, look at the anterior and posterior views of the bony pelvis, and as we mentioned previously, the special arrangements of ligaments leads to the generation of foramina. Again, review the formation of the obturator foramen as seen on the anterior view and the greater and lesser sciatic foramina. Major nerves that control muscle action of the lower limb course through these foramina. They will be discussed in detail when we study the lower limb. Finally, unlike with the pelvic vessels and nerves, there are no differences with respect to gender in the path taken by these nerves and vessels. Remember, the gonadal vessels and nerves vary significantly in their respective itineraries to the male and female gonads. This now concludes the first portion of the pelvic lectures.